I appreciate you all taking some time to join us for this webinar tonight. Um, I think this is a great format for you to learn a little bit and maybe ask some questions and get some some possibly some answers regarding help for sciatica, which many of us will experience in our lifetime. I personally have experienced it over the last 5 years intermittently, and it can be quite disabling at times. But fortunately for most of us, we get through it, we get over it, and most of the time it doesn't require a surgery, but on occasion for patients that aren't improving, surgeries might be options. And all right, there we go. So my background, so as I said, I'm a neurosurgeon. I trained for 6 years after medical school at the University of Utah in Salt Lake City, beautiful place. And from there, I went for a couple more months to another beautiful place in Murnau, Germany, to a trauma clinic. And I worked closely with what's called the traumatologist in Europe, which is very similar to an orthopedic surgeon that specializes in trauma. I spent a couple months there, and it was interesting to learn from another healthcare system. And the surgeon that I was working with was fantastic. He was world renowned. We had patients traveling from all over the world to see him. And then from there, I went to another very prestigious institute, the Rothman Orthopaedics at Thomas Jefferson University in Philadelphia, and spent a year there doing an orthopedic spine fellowship and learned a lot. It really helped kind of broaden things for me. Neurosurgeons are very good at some aspects of spine surgery. I think orthopedics can add a lot in terms of understanding the biomechanics of the spine, understand bone healing, and bringing those two fields together, I think ultimately is what's best for spine surgery, having some experience on both sides. And then after that fellowship, I was in practice for, I guess, 15, 16 years at the University of Illinois. And that was a great experience. I was a department head, headed up a fellowship and headed up residency training. But time came to move to a warmer climate, and that's what brought me down here. And the fact that Rothman Orthopedics was collaborating with Advent Health, which are both great organizations, and people that were here really drew me into this facility, having the opportunity to do really high quality subspecialty care. So what do I do as a spine surgeon? So most neurosurgeons do brain surgery and do some spine surgery. I've almost exclusively focused my entire career in practice only on spinal surgery. And right now, that's all I do. I only do spinal surgery. I don't do any brain surgery. So I evaluate and treat patients with spinal conditions. I evaluate whether surgery is a good option for their treatment. And in most situations, most patients are going to be evaluated by other providers, whether it be a physician or a physician assistant, before they actually get to see me as a surgeon. So we don't, in most cases, surgery is not the first option for most patients. So if someone's referred to our practice, typically they're going to see maybe some PAs that specialize in spinal conditions, or see some non-operative doctors that have treatments to offer patients with spinal conditions before they're considering more invasive treatments like surgeries that I offer. So in terms of what conditions I treat the entire spine from basically head to your tailbone. Most commonly, we're going to see most of our pathology that we operate on is in the cervical spine and then the lumbar spine. So in our neck and in our lower back. And the reason for that is that's where we have most of the flexibility in our spine. In the thoracic spine, we have our rib cage, and therefore that kind of limits flexibility. It's an internal brace essentially. So we don't see as much degenerative issues in the thoracic spine, but in the cervical spine and lumbar spine, it's very common. Today with sciatica, we'll be focusing on the lumbar spine. So radiculopathy, that's a disorder of pinched nerves, and essentially that's what sciatica is. Sciatica is a pinched nerve. So sciatica is a form of lumbar radiculopathy. And so those two terms are kind of interchangeable. Myelopathy, so that's an issue where there's damage ongoing in the spinal cord. I treat these conditions, but we don't see that in the lumbar spine because the spinal cord ends at the lower aspect of our thoracic spine. So most situations when there's degeneration, lumbar spine only pinches nerves. It doesn't pinch the spinal cord. I do a lot of scoliosis surgeries, which are deformities where patients develop curvatures either during childhood or later in life, what we call degenerative scoliosis, or from other surgeries. Sometimes surgeries can be performed that results in destabilization of the spine, kind of weaken the spine, and then gravity. Unfortunately, gravity works to bend us in half, and these patients develop curvatures as a result of um, instability from prior surgeries in some instances. A major part of my practice is spinal oncology, spinal tumors, and then low back pain and neck pain. And I would say those are probably maybe my two least favorite conditions to treat, because in general, surgery is really not that effective for low back pain and neck pain. Surgery is more effective for sciatica or nerve root pain. So what is sciatica? So sciatica is a referred pain that arises from a number of potential different causes, and we'll go through this, but it's a referred pain that travels down the leg. Oftentimes pain, there's sometimes numbness and tingling associated with it. Some patients might have weakness, but the key word is in most cases it travels down the leg. So in terms of our spinal anatomy, so there's a couple diagrams showing our spinal anatomy. So in the cervical spine, we have 7 vertebrae. Our thoracic spine, which is fairly rigid, has 12 vertebrae. And then our lumbar spine, we have 5 vertebrae. And then between the vertebrae are nerves that will exit the spine. And these nerves in the cervical region, so in your neck, these nerves form together in what's called a plexus, which ultimately form into the nerves that will travel down into your arm. So if you have a pinched nerve in your neck, you get arm pain. We call that cervical radiculopathy. Well, in the lower back, if one of these nerves in the lower back gets pinched due to a disease process, it causes pain in the distribution of that nerve. And then all of these nerves form into a plexus called the sciatic nerve. And therefore, we get the term sciatica, referred pain in the distribution of the sciatic nerve. So in terms of our spine and anatomy, so just looking at the motion, what we would call a motion segment, or 2 vertebrae in the joints between those 2 vertebrae. So the spine, every segment in the spine basically has 3 joints. So you have a disc, kind of a shock absorber in the front, and then in the back we have what's called facet joints. And these 3 joints promote some flexibility in the spine, but also limit the amount of movement at each of these levels. Um, so the function of the spine is one, obviously, we're bipeds, we stand and walk on 2 feet. So it has to support our body weight, support the weight of our head so that we can stand upright. And then the other thing it does is the purpose of the spinal column is to protect the nervous structures. The nervous structures might be the spinal cord, which travels from the base of your skull down to the lower thoracic spine, and then protect the nerves which are exiting between each of the vertebrae. So the disc is a very important structure. Like I said, it promotes flexibility. So the inner part of the disc is what we call the nucleus. It's kind of we describe it as gelatinous, but it does have some water content within that disc. So it can compress, it has some compressible properties. And then surrounding that nucleus is basically a thick ligament. It's kind of designed like a radial tire that allows for rotation in the spine and holds the nucleus in place and provides some support for the vertebrae so that they stay in appropriate alignment. So a lot of people ask, do I have degenerative disc disease? Well, most of us are going to have degenerative disc. Almost all of us in our lifetime are going to have degenerative disc. And it's a question of whether you have symptoms from the degenerative disc. So I really don't like the word disease. Degenerative disc disease gets floated around a lot. I don't like the term disease because it's common. It's kind of normal with aging. There are definitely some families that might have genetic issues that result in more spinal arthritis and more degenerative disc disease than others. But in general, not a disease process for the average individual. So yes, everyone will develop some degeneration in disc and spine with aging. So in terms of what happens, so early on, so what's unique about a disc and a spine is it doesn't have a blood supply. So it receives all of its nutrients from the adjacent bones. And like I said, in certain families, individuals, um, that blood supply can get interrupted, or the cells might not be as viable, or they don't survive as well in some people as in others. And so once those cells die within the nucleus, those cells produce proteins that attract water in there and keep the disc hydrated. So after the disc loses its hydration, it will dry out inside, kind of like a raisin, gradually collapse, and then cracks can form within the ligament or the annulus, and then essentially it becomes almost bone on bone with a lot of inflammation. This is a bone spur here forming in front of that disc, and bone spurs can also form in the back, and might cause pinched nerves and other issues. So the biggest factor in terms of disc degeneration is genetics. There's other factors that contribute. Certainly trauma can be one, but I would say genetics is a big factor. Smoking can be a big factor because of that um, sensitivity of the disc space in terms of receiving its nutrients from the adjacent bones. Smoking changes the small blood vesicles, the small vasculature around the disc, and can promote disc degeneration. So, and this was a study that was done at Rothman at Thomas Jefferson there in Philadelphia. So we're just looking at, we're looking at MRI scans on normal people. These are patients that were asymptomatic, no symptoms. So, even by age 20 and 30, a lot of patients are going to have signs of some disc degeneration, what we call the bulge. Some might have herniations, and as we age, as we get up into our 60s, 70s, and 80s, all of us are going to have some degree of degeneration within our spine, or what we call spinal spondylosis, spinal degeneration. So what can go wrong in the spine as we age? So all of this degeneration, as it occurs, it can cause compression on the neural tissues, that being the spinal nerves or the spinal cord. So spinal nerves is what produces sciatica. So how do you know if you have sciatica? How would you know? So sciatica is typically an intense pain in your butt. So I kind of specialize in pain in the butt. Some people will describe it as their hip, but I don't really get to the office. It's kind of really back on their bottom side. And oftentimes that pain will radiate down the leg, and it radiates in a distribution of the particular nerve that is irritated. So, like I said, all of these nerves coming out of your back, we have them named lumbar one down to sacral one. They contribute to the sciatic nerve. And depending on which one of those nerves is compressed, will give us the distribution of the referred pain. So a pinched nerve in your back can cause pain that would travel down the leg. So if it's the lumbar 4 nerve, it would typically travel in this distribution, and so forth with a lumbar 5 and a sacral 1. Most commonly, we'll see degenerative disc or degenerative problems occurring in the lower lumbar region and between lumbar 4-5 and lumbar 5 sacral 1. So we oftentimes have pain that will go all the way down the foot. But everyone's a little bit different. Sometimes we have patients that just have a pain in the butt. You can certainly have a pain in the thigh from a lumbar 2 or 3 issue, but it's much less common. Um, Pain typically increases. It with certain positions, it's positional. So oftentimes patients say, "Well, I feel very comfortable if I'm laying down, but the second I get up, I get a pain that shoots down my leg, or if I try to stand up straight, I get more pain." Some disc herniations, particularly in the lower back at L4-5 and L5-S1, can cause increased pain with sitting. So I can almost make the diagnosis when I walk into the exam room and I see a patient standing there. There's a chair inviting them to sit down, but they don't want to sit because their pain increases. So I can almost make that diagnosis of a herniated disc in their lower lumbar region based on how they look when I first walk in the door. Commonly, they'll have numbness and tingling, and a similar distribution is pain. And some may have back pain. Not everyone will have back pain. So, back pain, doesn't back pain, isolated back pain by itself is not sciatica. So, sciatica is a pain in the butt that travels down the leg. Back pain is a whole different animal. A lot of different causes for back pain, and that's a whole different talk. And weakness is pretty rare in most situations with sciatica. We do see patients that can have weakness. If you do have weakness, it's a reason to maybe see your doctor sooner than later. And we would consider MRI scans sooner than later in individuals with weakness. So what should I do if I have sciatica, symptoms of sciatica, and I'm worried about it? Should you go to the emergency room? Do you call an ambulance? Do you call your primary doctor? I would say for most patients, symptoms are mild and moderate, and they're typically non-emergent. They usually come on, they can come on suddenly, but oftentimes it's gradual. You suddenly have some sciatica. You'll have a pain in the butt that's kind of, you know, it's there, but it's not disabling. And then it can get worse in the coming days, weeks, and months. So in terms of what you should really do if you have sciatica, so I would say activity modification. So if you're starting to feel some pain in your buttock and traveling down in your leg, and you know you're big into working out and you know whatever exercise it might be, you might want to back off for just a little bit to try to let that inflamed nerve settle down. So you know I might back off of jogging because that's pretty jarring on your lower back. I might back off heavy weightlifting, repetitive bending. You know, try to take it easy with your back for a little bit. Try to walk. We don't want you laying around. We want you up and moving, but you need to be sensible. So avoid, you know, real rigorous activities and jarring activities to try to let that nerve inflammation settle down. Usually, most patients we'd recommend an NSAID. So an NSAID is a non-steroidal anti-inflammatory drug, and examples might be Aleve or ibuprofen, over-the-counter medications. So you can use these at home. You know, if you have a history of kidney disease, renal disease, or some heart disease, so these might be the contraindications where you shouldn't use those medicines. But if you don't have those contraindications, if you've used those medicines before, it'd be a consideration. And you might want to consider using high dosages. So like I've said, I've had sciatica before. And there's times when I've used 12 ibuprofen in a day, which is about your limit. So I'd use four. I typically have it with meals, kind of protect my stomach. And it really helps settle down inflammation. It can help with the pain. Stretching exercises. So if you look online for stretching exercises for sciatica, you'll find a bunch. There's some exercises called McKenzie exercises, which can be helpful for some patients. And I'll show that in a little bit more detail here. I think it is reasonable to call your primary care physician and maybe, you know, try to schedule an appointment with them, thinking that, well, if the sciatica continues, I'm going to have to do something. So get an appointment scheduled. And then try to start some physical therapy. So I'll have a lot of patients say, well, you know, I heard physical therapy doesn't work for sciatica, or you know, my copay is $50 each session. Well, the issue with physical therapy is pretty much mandated by most insurance carriers these days. So your insurance carrier might force you to complete physical therapy before they allow for advanced imaging such as MRI scans, and before they allow us to consider interventions to help treat your sciatica, interventions such as surgery or epidural injection. So it's necessary to get physical therapy going as early as possible, because if your symptoms become disabling, your insurance carrier these days, they don't care. You have disabling pain, they're still going to force you to do 4 weeks of physical therapy at a minimum before they can improve a lot of our treatments. So do I need an MRI scan? So in most situations, I would say we initiate conservative treatment before we're ordering and getting MRI scans. And like I said, typically insurance carriers don't allow much treatment or expensive workup. So an MRI scan, you know, probably costs on average, I don't know what insurance carrier might pay, but it's, you know, it's going to cost somewhere probably $500. So it's pretty expensive. So the insurance carriers want you to try some conservative treatment, particularly physical therapy is one of the boxes they want you to check. And oftentimes NSAIDs, non-steroidal anti-inflammatory medications. So it's not until you complete the physical therapy that they'll actually approve an MRI scan and pay for that MRI scan. There are situations, so if you have weakness, urinary incontinence, you might need an MRI scan urgently. So in that case, if you come to see us in the office or you go into the emergency room, that might be situations where an emergency room is a reasonable option if you have weakness or urinary incontinence. And in those situations, getting an urgent MRI scan shouldn't be an issue with the insurance carrier. So at Rothman Orthopedics, we believe in a multidisciplinary approach. So we're going to have a lot of different options for you from observation. So some of these issues can resolve on their own with observation, giving things a little bit of time, letting inflammation settle down works for many patients. NSAIDs, non-steroidal anti-inflammatory medications can help settle down that inflammation and help with the pain, relieve the pain. Steroids, so steroid pills are an option. Again, this is probably a stronger version than the NSAIDs in terms of reducing inflammation, helping with pain. Physical therapy can definitely help a lot of patients with sciatica. And like I said before, it's a box you're going to have to check in order to have other more invasive treatments like epidurals and surgery, and maybe you might need to complete physical therapy before your MRI is done. Epidural steroid injection. So this is a steroid that's delivered into the spinal canal around the nerves, kind of a focused treatment of the anti-inflammatory, reduces the side effects of the steroids throughout your entire body, and pretty much puts the medication where it's needed. And then there are surgery options. So at Rothman, we've got a number of different physicians, different type of physicians that might see you for sciatica. We have an excellent group of physician assistants that work very closely with the spinal surgeons and the spinal physiatrists. And they're oftentimes, they might be the first person that a patient is going to see. And they're kind of going to head up the case and kind of be a case manager for you. So they're going to do an evaluation. If they feel you need something urgently, they're working in the clinics with the surgeons or the physiatrists who do injections. And if they think you need an urgent treatment, they might grab one of those physicians to come look with them and get an opinion urgently. But otherwise, they are, kind of initiating a lot of treatments, initiating physical therapy, ordering MRI scans, and kind of getting your case up and going. To see a spinal surgeon sometimes can take 2 months or 3 months, or a spinal physiatrist the same. So getting in with the PA in a week or two is a great option for a lot of patients. It gets the ball rolling in terms of their treatment. Sports medicine doctors. So these are doctors that specialize in sports medicine. And sciatica can be a sports injury. So we have a number of excellent sports medicine doctors in Rothman Orthopedics, Florida offices that can help you. Spinal physiatrists. So these are non-operative spine specialists that can offer you various treatments from epidurals to other procedures to help with spinal conditions. We have spinal surgeons that obviously do surgery like myself. And then we have physical therapy in a lot of our offices. So in terms of our potential causes of sciatica, disc herniation is a very common cause. Arthritis, like I said, all of us are going to develop arthritis. That arthritis can gradually encroach on the spinal canal and result in nerve compression. This particular image can show you there's multiple areas where a nerve could get pinched in that spinal canal. And it could be from a disc bulging, or it could be arthritis in these joints back here, what we call facet joints, that can gradually enlarge and grow into the spinal canal and cause nerve compression. Facet cysts, so there are cysts, arthritic cysts, so these aren't cancers, but these are arthritic process. There's a lubricating lining to most of the joints in our body we call synovium, and that lubricating lining in situations of arthritis can overgrow and cause nerve compression and severe nerve irritation. Spinal stenosis, so that's a condition. Most commonly when we hear spinal stenosis, we're thinking about, usually it's going to be an older individual, and it's gradual spinal arthritis where the disc degenerates, it bulges back into the spinal canal, causing a little bit of narrowing, and then ligaments thicken, joints enlarge, and the spinal canal goes from the size of a quarter down to the size of a pea, and then that causes significant nerve compression and can cause nerve irritation and produce sciatica. And then other, rare causes are going to be tumors. So if someone's had a history of a cancer, it is something to think about. And maybe in those patients, we're going to get an MRI scan earlier than others. And then there's a condition called piriformis syndrome. So piriformis is a muscle that the sciatic nerve passes through. So in certain athletes, that piriformis muscle can be large and can actually constrict on the sciatic nerve. This is very rare. So most patients, I would say, that come to my office that say, well, I have piriformis syndrome, most of them actually have sciatica from nerve compression, more commonly in the back. but it can be a possible um, cause for sciatica if we don't find a pinched nerve in someone's back that we're considering piriformis syndrome or some of these other more rare conditions. So a disc herniation, this is probably the most common cause of sciatica. So this can occur at all ages. So I've operated on teenagers. I've operated on a lot of teenagers with disc herniations producing sciatica. And it can occur in older adults. I would say probably most commonly we're seeing it from, the 30s, 40s, and 50s, but it can occur at all ages. So the disc, here's the disc in the front. So it can have a piece either bulge where the inner part of the disc pushes the ligament back into the nerve, or we call an extruded herniation where the inner part of the disc, the nucleus, that material absolutely leaks through a crack in the ligament, the annulus, and produces an extruded herniation that can irritate nerves. Oftentimes, disc herniations will respond to conservative non-operative treatments, and disc herniations can heal. So that's very important to consider. So, if you have sciatica from a disc herniation, if you can get through that, first couple months of pain with anti-inflammatories or epidural injections, it's very possible that your body can heal that disc herniation and you can avoid a surgery. So it's always great to avoid surgery if you can. Other treatments, so NSAIDs, like I said, if it's early on, definitely I would consider NSAIDs if you don't have any medical contraindications. Oral steroids, oftentimes something we will consider in the office. So if we're seeing a patient with, 1 to 4 weeks of sciatica and that really haven't started any treatments yet, we'll give them an oral steroid, and usually they'll feel a lot better within a couple of days. And that steroid will last, typically we'll do somewhere between a 5 and a 10-day course of steroids. And it can kind of really help with their pain. It allows them to participate in some of the conservative treatments, allows them to get into physical therapy. Epidural steroid injections can be an excellent option for some patients. So if you have an extruded fragment that's causing significant nerve inflammation, we put a steroid, inject a steroid around that nerve. It can be life-changing. It can really, improve your quality of life, and your body heals that disc herniation and you avoided surgery. So a great treatment option to consider. But we still do a lot of surgery. So surgery is an option. We call it microdiscectomy in most situations, where we're going in to remove a small fragment of disc that's causing the sciatica. In terms of exercises, there's a program called McKenzie exercises. You might, if you participate in physical therapy, you might receive some McKenzie exercises. There's a lot of information online about McKenzie exercises, and it can work for, the key word here, some disc herniations. In theory, how McKenzie exercises work is the extensor. So we're trying to extend your lumbar spine and stretch that disc out. In the process of stretching the disc, you're kind of pulling that that ligament back into place, trying to reduce the amount of nerve compression and therefore reduce nerve irritation. But if you've had a leakage of a disc where the disc is actually leaked out, an extruded herniation, McKenzie exercises is not going to suck that herniation back in. Epidural steroid injection. So here's a diagram kind of showing what an epidural is. So the epidural can be injected here into the center canal, or oftentimes we consider putting it into the foramen. So this is a space where the nerve is leaving. So it's a great place to put some medication. The medications will travel up and down. So we try to put it as close as possible to the area of symptoms. It might not always be the exact spot where we see the disc herniation. We might put a level below, knowing that those medications are going to go up the spinal canal just a little bit. And this is a great option for a lot of patients. It's a great anti-inflammatory, helps with the pain while the body is healing. So the body's going to heal that disc herniation. So surgery. So surgery is often considered for those patients that either fail conservative management, so they still have pain despite trying physical therapy and an NSAID. Patients don't have to try an epidural in order to have surgery, but most insurance carriers will force that patients to try physical therapy and an NSAID prior to approving surgery. And then, in addition, we oftentimes consider surgery for patients that have significant weakness. So if you have a foot that's dragging the floor, when you're walking, it's slapping on the floor and you're tripping, what we call foot drop, which is a common fairly common thing that can occur with some disc herniations. Overall weakness is very rare, but when we do see weakness, probably the most common weakness that we see is a foot drop. So if you had a foot drop where the foot is dragging the floor, then we consider that more urgent, and we think that getting the pressure off the nerve with a surgery, getting that disc off the nerve, improves the likelihood that that patient's going to get their strength back. So a microdiscectomy in general, it's on a scale of 1 to 10 in terms of complexity. It's a 1 on a scale of 1 to 10. It's the easiest surgery that I perform. It's a 45 minutes to 60-minute surgery in most individuals. You wake up from surgery in the recovery area, sciatic pain is gone, and usually the back pain is very mild and manageable. It's done through, a 1 to 2 inch incision at most. We don't cause a lot of damage and destruction in the spine, and in general, it's very successful for the treatment of sciatic pain. But usually after surgery, we'll recommend some activity restrictions for a few months because we want that disc to heal up. The biggest risk with this surgery is going to be a reherniation where you have another fragment of disc leak out through that same defect in ligament. So we kind of want to let that area heal up before really stressing things. Lumbar spinal stenosis is the pretty common term. So in most individuals, spinal stenosis, so this is an MRI scan. Here is a great image showing spinal stenosis. So you have a disc that's bulging back here. You have thickening of the ligaments and probably enlargement of the joints. It's narrowing in the spinal canal. Here's an MRI scan on the patient that we operated on. So here, the white stuff is spinal fluid, and we can see individual nerves, whereas here, we focus right in this little area, we don't see much white. So all the spinal fluid has been displaced, and all the nerves are stuffed into that tiny little area. And that can produce sciatic pain. So spinal stenosis, oh, somehow I lost this slide. I think I had. So in terms of spinal stenosis, so typically, often patients with stenosis have pain that increases with standing and walking. So with stenosis, when you stand up, it causes the ligaments to buckle a little bit more and narrows the spinal canal just a little bit more, starves nerves for the blood supply, and then they give you the sensation of pain in your buttock and your legs. In a lot of situations, it's in both legs, but it can be in one leg and very similar to sciatica. Spinal stenosis isn't always in the canal. There can be situations where it's in the foramen. And we'll go through that. I have a case later on that I'll show you with a patient with foraminal stenosis, which is a little bit more challenging case. So in terms of our treatments for spinal stenosis, it's very similar to patients with disc herniations. We recommend physical therapy for most patients. Most insurance carriers are going to mandate that. Epidural steroids can be an excellent option to consider. The little difference here, a patient with a disc herniation, I said, is going to oftentimes heal. That disc herniation will go away. Whereas if a patient has severe spinal stenosis, let me repeat that, where the spinal canal has gone from the size of a quarter down to the size of a pea, and all those nerves are compressed as they're traveling through that area. The epidural it doesn't cure that. An epidural is a very reasonable option to consider, but oftentimes it's temporary. So, pretty common scenario is a patient might start out with an epidural, see 2 or 3 months of relief, and then their pain returns. And in that situation, if the pain is returning and we can offer them a simple surgery, I oftentimes recommend that. Long term, it's kind of going to be a recurring problem. Epidurals probably aren't going to be the cure. And then surgery, oftentimes, is a very small surgery, very similar to the surgery for a microdiscectomy, except we're not removing disc material. We're doing a small surgery to enlarge the spinal canal. And I would say it's probably the best surgery that I perform. My happiest group of patients are patients that I have a minimally invasive way of doing laminectomy, where we preserve as much of the structure in the spine as possible. Patients have a great recovery, immediate relief of their pain. And long term, we're not, with this minimally invasive surgery, we're not creating structural issues. So most patients with sciatica are going to have, if they don't improve with conservative treatments, in most situations, we're going to be able to offer them a very small surgery as an outpatient. But there are some patients with sciatica that need larger surgeries. And those situations can be when there's instability or abnormal alignment in spine, something we call spondylolisthesis. There can be scoliosis where we've had prior curvatures. And then there can be foraminal stenosis. And I have a case also here shortly, a case we did recently, where a patient has severe foraminal stenosis where the nerve is leaving. That's a little bit more challenging. In order to get that area of nerve compression opened up, we end up removing the entire joint. In that case, that requires stability, a stabilization procedure with screws and rods and a fusion. In general, you don't want a fusion procedure unless you absolutely need it. So many of these patients, we're going to try exhausting conservative management, and surgery is the last resort option. But then again, there's going to be a number of patients that fail those treatments, and a fusion surgery might be their only option. And if you have disabling pain from sciatica, it can be a very, very reasonable option. So this next case, this is such an example. It's the actual patient I operated on yesterday. And one of the main reasons I'm showing this case is because he kind of reminded me every day times the day after, oh, you remember you have a talk tomorrow night? And I saw him this morning, oh, you remember you have a talk tonight? I'm like, oh yeah, all right. I think I'm gonna include you in my talk now. Because you had sciatica and you did very well with surgery. And the surgery is a little bit more complicated because of that foraminal stenosis. So this is a 78-year-old gentleman. He's had some severe left leg pain for about 3 months. It's disabling. So it's pain that radiates down his legs. He's getting to the point where he is very sedentary. He has trouble walking, might have some weakness in the left leg. And so we don't jump right to surgery. He goes through physical therapy at first. It really doesn't help at all. I see him in the office. We go over his MRI scan, which I'll show you in a second. I explained to him, you have a complex problem. I do see a lot of nerve compression. I am concerned it could require surgery, but it's going to be a fusion. So I would recommend you try an epidural first. He tried it. Unfortunately, it only lasted for a couple of days. So here's what he is dealing with. So here we have his MRI scan. So this is the central canal, which I showed before. So here's a little bit of enlargement of the ligament here and joints, but there's adequate space here in the center canal for the nerve. So there's not, we can still see white, which is spinal fluid. He has some disc here that have degeneration, which is very common at 70 years old. So this one's collapsed, tiny little bulge, a little bit of bulge, a little bit of bulge. So those are very common findings to see. So in terms of looking at a center canal, it didn't look too bad. But now when we came up, oops, sorry. When we came over to the left side, now we're going to look at what's called foramen. Hopefully you can see my arrow. So this is a normal foramen. So there's a nerve. The white is fat, which is a little cushion around the nerve. Here again, we see the nerve and fat. Here, you see this? I know where the nerve is somewhere in here. It's probably right there, but we don't see any of that fat, that cushion. So this is severe foraminal stenosis. So he has severe arthritis within this disc, severe arthritis within these joints that's causing nerve compression. He also has a little bit of scoliosis, which is contributing to this. And then the two nerves down below look pretty good. But then when we looked on the other side, he also had nerve compression on the right side between 4.5 and 5.1. So here are his x-rays. So here we can appreciate this is a mild scoliosis. Some patients can have scoliosis, 30 degrees, 80 degrees. Those are more concerning. But he has a little bit of scoliosis. So this scoliosis results in nerve compression here. So as that spine tilts to that one side because of the scoliosis, it pinches that nerve as it's trying to leave. So he has a pinched nerve here on the left side, and then he has pinched nerves here and here on the right side from just this mild scoliosis and the arthritis. This is a view from the side. So otherwise, we can see it's got some bone spurs in the front, deterioration in the disc where they've collapsed in height, but its spinal alignment's pretty good when we look from the side. So this is more complex. In order to get that nerve tunnel open, I have to remove the joint, what we call the facet joint. And then we're concerned that that's going to create instability. So here we're looking at a fusion. So he ended up, we removed the joints here. We put a spacer in, which addressed the scoliosis. So it makes kind of straighten the spine out, that area. We also put a spacer down here to improve healing on the right side. We move the joints here and here to free up these nerves on the right side and then free up the nerve here on the left side. And we put screws and rods and did a fusion. So this is a big deal. This is something, this is kind of a last resort option in most patients, but it is a very viable option for some patients with sciatica. So if you have disabling sciatic pain, sometimes it requires a fusion surgery to get better. And this gentleman, he did great. This was a 2-hour surgery. He woke up, he had immediate relief of his left leg pain, and he was actually discharged to rehab today with very little surgical or back pain. That's not normal. Okay, most patients that have a fusion like this might be in the hospital for 3 or 4 days with pretty significant back pain and require pain medications and pain management. But this gentleman bounced back very quickly, and I'm very optimistic he's going to get his life back and hopefully get back to doing the things he enjoys here in the coming months. So just to summarize things, so sciatica, most cases they're going to respond to non-operative treatments. And you can initiate some of these non-operative treatments on your own before you see your physicians, NSAIDs, looking up some stretching exercises. Um, Surgeries most commonly are small non-fusion surgeries. So these are oftentimes an hour surgery, outpatient, and patients do great. Very gratifying surgeries, usually a very easy recovery for most patients. And if you can avoid a fusion surgery, it's definitely in your best interest. I would tell you if you have someone that's recommending the fusion surgery, I typically recommend most patients get a second opinion before having a fusion. I've seen a lot of patients have been recommended a fusion previously, and I see their case and like, oh, this is a simple non-fusion surgery, and you're going to be better off long term if you don't have a fusion. But there are instances where fusion surgeries might be needed in some of these patients for either foraminal stenosis because we need to remove that joint, so one of the three joints, scoliosis where they have curvature in their spine, so we're worried decompressions can make their scoliosis work, or there's situations called spondylolisthesis, which is slippage of the vertebrae, which can cause nerve compression, and sometimes these will require stabilization with screws and rods and a fusion. So I hope this was helpful to some of you if you're having sciatic pain, and um, appreciate your attention. I'd be happy to take any questions if you have any. Let's see if we got some questions here. All right, I'm gonna read through the questions that are posted here. Are injections suggested for sciatic pain if first course of action does not work? I would say injections are very reasonable. It's not every patient that I'm recommending an injection for sciatica. Some of it depends on what's going on. If you have a disc herniation, oftentimes I'm going to recommend an injection unless you have weakness, because like I said earlier, with a disc herniation, there's a chance the body is going to heal itself. So you could make a complete recovery. The injection kind of helps you get over the inflammation and disabling pain while your body is healing. Whereas if I have, say an older person with severe spinal stenosis where their spinal canal is just completely closed off and they're having sciatica as a result, long term, I am doubtful that epidurals are going to work long term because there's such severe nerve compression there. It's not going to heal. Okay, there's always going to be nerve compression there, and I feel like surgery, if a small surgery could fix that, it might be a very reasonable option. So oftentimes, if someone has severe spinal stenosis, I'll offer them surgery. Well, I explain to patients what their options are. I say surgery is an option. This is what surgery entails. These are the risks. You can try an epidural. I don't think there's much downside of trying it besides the time. I'm not optimistic. It might not work long term. Next question. If I had a bulging disc and a compressed nerve and had two epidurals, second one worked, L4-5 and doing much better. However, I feel that I still have a weird sensation in my shin after a year. Will that ever feel the same again? Hard to say. So you could have a little bit of nerve damage in your back, or you could have a paresthesia, which is from nerve irritation. So it's not a full-blown pain, but numbness and tingling that's coming from nerve compression in your back, and it may or may not get better with time. It may, if I saw you and you say, well, could you fix it with a surgery? I'd probably say maybe. If there's severe nerve compression there and we relieve the pressure on there, there's a chance that numbness and tingling would go away. But I usually tell patients that numbness it doesn't always go away. A lot of times it will get better, but not completely resolve. I would say that surgery, I would much prefer to operate on someone with pain, severe disabling pain, than numbness and tingling. Hopefully that answered your question. Um, what is the difference between laminectomy and discectomy? So laminectomy is an enlargement of the spinal canal, and we don't touch the disc. Whereas with a discectomy, we're actually doing a little bit of a laminectomy. We do what's called usually a hemilaminectomy, a half of a laminectomy that gives us exposure to the nerves and exposure to the herniated disc, and then we remove the disc material. So there's a little bit of a difference. I would say patients would I would much rather do a laminectomy than a discectomy because patients do better, I think, long term. And the reason for that, a discectomy patient has a risk for reherniation. So there's a defect in that ligament, and they could have another herniation occur in the coming weeks, months, or years after surgery, whereas a laminectomy patient doesn't have that defect in the ligament that you know through the disc. And in general, does better after surgery. Both patients do very well. Let's see. Thank you. Thank you. Chiropractic. So a question about chiropractic. So I think chiropractic is also a reasonable option for sciatica. Um, I've had close relationships with chiropractors. I have some close friends that are chiropractors. So I think they do have something to offer. The question is, you know, if it comes to needing an advanced treatment such as an epidural or surgery, sometimes the insurance carrier might not count chiropractic treatment towards physical therapy. So oftentimes I recommend doing so that you're kind of progressing along and checking that box. Um, so that if you need something done, you know, you've had your physical therapy completed. My wife has had an epidural, but still has functional problems in her left leg. So I guess the question there is, you know, what are the functional problems? Is it numbness and tingling? Is it weakness? Um, if it's weakness that's been long-standing, and she doesn't have pain, then surgery may or may not be an option. Honestly, I'd be less enthusiastic to operate on someone with just weakness and no pain. Have I done it before? Certainly, and sometimes the weakness can get better. Um, so that would be someone that, you know, she might want to be evaluated by a spinal surgeon or by a neurologist. Is there some other cause for the functional problem she's having in her leg? Looks like I have a patient seeing me next week. I'll see you soon, Sheila. Is radiculopathy the same as stenosis? So radiculopathy is the symptom. Stenosis is the radiology finding or term. So stenosis means narrowing. So you can have stenosis and not have any symptoms, or you could have stenosis that produces radiculopathy, a stenosis that causes compression on the nerve and irritation of the nerve. Any thoughts on stem cells in the lumbar spine? I would say buyer beware with stem cells. I don't think we have any good scientific data that shows that stem cells alters the degenerative process in most situations. Um, you know, yeah, we can regenerate a disc um, in a rabbit in a lab when we cause mild and moderate degeneration and then add stem cells. But in most situations, by the time a patient is symptomatic, stem cells, even if they were injected into the disc, um, aren't viable. So that there's been permanent changes in the way that the disc gets its nutrients, and those stem cells won't survive. And I would say most of the stem cell centers that I've seen either in the US or abroad, um, and unfortunately there's a lot of them, I think they prey upon people. They're very costly, and I think they're not really following science. So I think there a lot of ineffective and costly treatments. So buyer beware. But if finances aren't an issue, certainly can be an option for some people to consider. Are there any emerging research therapies showing promise in the treatment of sciatic pain? Yeah, I think we've got a lot of great treatments right now for patients. I mean, most patients we can get better with sciatica. Um, it's pretty rare that we have someone with sciatica that we can't get better with either conventional non-surgical treatments, therapy, epidurals, time. And then surgery oftentimes can be a cure for sciatica. For patients that have disabling sciatic pain, that multiple surgeons have said no further surgery is an option. There are some technologies we call stimulators, where we're kind of disrupting the brain's the brain and spinal cord's processing of pain. So these get placed into the spinal canal, electrodes get placed in the spinal canal and kind of to disrupt the pain mechanism, pain signals. And then there's some electrodes that can get implanted to the brain that help with pain as well. Next question. I have experienced severe pain from my buttocks down both legs with tingling, also difficulty walking. I had the epidural, but it didn't last. MRI shows L3-4 and 4-5 damage. So hard to say what that means. So is the damage degeneration of the disc, arthritis, or is it stenosis? Your symptoms are very, you know, your symptoms sound like stenosis with severe pain in your buttocks, down your legs. And I'd recommend you give us a call, send us your MRI, and be evaluated by one of our non-surgical specialists or surgeons, and see what treatment options there are available for you if you do have stenosis. So the MRI will determine whether laminectomy or microdiscectomy is necessary. Yeah. So that MRI scan shows us what's going on in terms of, it guides us. So is there a leakage of disc, a disc herniation? So if it's a disc that's herniated back and is causing a nerve compression, then it's usually a microdiscectomy. Whereas if it's not disc material, if it's simply enlargement of the ligaments and enlargement of the joints from arthritis and a little bulging of the disc that's contributing to stenosis, usually we'll do a laminectomy and not remove any disc material. So the MRI kind of guides us in terms of what we need to do to help with someone's sciatic pain. Patient with spinal muscular atrophy, having severe sciatica, occurs with driving 20 minutes, goes down the foot. I would say I would recommend that you start by seeing probably a non-surgical specialist at first to kind of get the ball rolling. Order the appropriate studies, make sure that the appropriate therapies are done to appease your insurance carrier to allow you to have other treatments, and then present you with options, where those options might be medications, injections, epidural injections, or possibly surgeries. But I think getting into a spine specialist is very reasonable. As I mentioned earlier, we've got a number of specialists from spinal physician assistants that work very closely with us. They know what they're doing. They work hand in hand with us in the office, and if they see a patient that has concerning findings, they will oftentimes grab me and ask me to come see a patient. I'm more than happy to do that, squeeze patients in that way. Or if a patient prefers trying non-surgical routes, we set those patients up to consider epidurals and other treatments with some of our spinal physiatrists, non-operative spine specialists. I saw another orthopedic group have records from previous treatment, including physical therapy, recent MRI. If I were to change to Rothman, yeah, we would take into account. So if you've had previous treatment, we take that into account. It's not like, all right, you saw another orthopedic group, they did physical therapy and epidurals. We're not going to force you to do those things again. Now, physical therapy was, say, 2 years ago, and I'm recommending you need a fusion for some crazy reason. You have a spondylolisthesis, a slippage, or foramen stenosis. Some insurance carriers mandate that physical therapy be completed within 6 months of surgery, so they might force you to do physical therapy again. But I think if you called our practice, we could get you scheduled with one of our spinal physician assistants who know what they're doing. They're going to get you on the right path. And like I said, there's surgeons and non-surgical spine specialists there in the office that work closely with them, and we can get present you with treatment options, whether that is repeating conservative treatments again or considering surgeries. Uh, Let's see. I think you move back to the screen. All right. Are people able to hear me? Hopefully so. Um, any thoughts on PRP? So I'd say PRP in the lumbar spine. I do not know of any great data for PRP in the lumbar spine. I would say the mainstay is epidural injections. I would think that most insurance carriers aren't going to approve PRP in the lumbar spine right now, but um, I definitely would have to look at the recent literature. Maybe there's something new out that I'm not aware of. How many epidurals are too many? In general, epidurals usually limited to about 3 or 4 in a year. I think epidurals in general are very low risk. Steroids in general can cause deterioration of bone and other side effects. If you take them steroid pills over and over again. So if you're on oral steroids chronically, it can cause deterioration of bone, a lot of side effects, whereas the epidural is much lower dose. But generally, we limit epidurals to 3 to 4 injections per year. I have someone here. I live in DC. Any offices in the area? I do not believe that we have any offices in the DC area. Um, if you wanted to contact us, I do a lot of telemedicine. I treat a lot of patients that travel in from other states, and I'm happy to review MRI scans and images and give you a phone call, kind of um, make things easy at first. And surgery might be an option. I do have patients that travel in from other states for surgery. It's not most convenient, but it at least give you another opinion through a simple telemedicine appointment. How many months typical to recover from spinal surgery for fusion, and will it last for many years? So, recovery, I would say it varies patient to patient and it depends on the extent of your fusion. I do anywhere from a single level fusion where we're locking two vertebrae together. Probably the most common scenario for sciatica is going to be spondylolisthesis, where there's slippage of two vertebrae. Usually it's between L4-5 or L5-S1. And we have to do a fusion where we lock those two vertebrae and we're trying to get those two vertebrae to actually grow together. So after that, so recovery wise, the first couple of days can be rough after a fusion in terms of pain. Um, a lot of patients are off pain medicines. I would typically say 1 to 4 weeks, depending on the extent of fusion. Patients are up and walking usually the next day. Usually when patients come back and see me at a month, most of the fusion patients are pretty happy. Most of their surgical pain has gone away and their sciatic pain is completely resolved. But then I have restrictions for 3 months in terms of bending, lifting, and twisting. So we want them to kind of reduce stress on their lower back while the bones are trying to heal and fuse together. And then how long will it last? So the fusion, if the fusion works where the bones actually go together, that fusion lasts forever. Okay. Unfortunately, not all fusions work, and there's a lot of what sound like sexy techniques, minimally invasive fusions and things like that. Um, but some of these, what sounds like sexy, short in and out surgeries results in an inadequate fusion where the bones don't heal. And then what happens is the screws and rods come loose and everything falls apart. And then we have to redo that fusion, and that's a more complex surgery. So, um, if you have a good fusion surgery where things are done right, appropriate carpentry, appropriate stability from the screws, and the fusion heals, that area lasts forever. The issue is what happens to the areas above and below. So, a downside of a fusion is what we call adjacent segment degeneration, where joints next to the fusion now see more stress, work a little bit harder, and develop arthritis. So most patients where I do a fusion in the lumbar spine, I tell them, you're probably going to be back somewhere 10, 15 years and have another procedure. If they have a lot of pre-existing arthritis already at those other areas, I tell them it might be 5 years and you're back to have another fusion procedure. And then sometimes the techniques that some surgeons use creates instability at those adjacent segments, and patients can be back in a couple of years. So I always try to preserve as much ligament and structure right up above at the top of any fusion to prevent deterioration occurring above those fusions and problems down the road. But yes, one fusion can turn into more fusions in a lifetime due to what we call adjacent segment degeneration. Um, let's see. What is PRP? So PRP is platelet-rich plasma, and basically, someone takes your blood, spins it down, and harvests the platelet-rich plasma. And platelet-rich plasma can have some anti-inflammatory properties, some healing properties. It is used to treat a number of different things from um, elbow injuries, so professional athletes, professional baseball pitchers that have injury to their ulnar collateral ligament, which often comes from a joint surgery. They have PRP injected into that area to improve healing. There can be PRP injections into the knees and other areas. I would say it really hasn't gained connection in the spine. It's very different. This space is very different than a lot of the other joints, and I personally don't see a role for PRP in the spine. All right, I think hopefully that covered everything. Melba, do you see any other questions?
No.
I think you're on mute, Melba.
Oh, there I am. No, I don't,
There you
doctor.
go.
No more questions. Fantastic. Thank you
All
so
right.
much for taking the time to present today.
Thank you. And appreciate you hiding my background too. Yeah, I'm actually sitting on a beach right now, so not joking. I
Oh,
wish I was on a beach. It's beautiful out. So,
oh, well, I appreciate it. You had a good show.
and
A good
will you
turnout.
share contact information with everyone so they have a way to contact our office if they wanted to
Yes,
request self-referrals? And
I
with
will.
the self-referral process, I just want to, you might end up seeing a physician assistant. And I hope people don't get discouraged with that. These are they're critical to us to allow for access. If I saw every patient that was referred with a spinal condition, I wouldn't have any time. There'd be wait times of 3 and 4 months in my office. I won't have time to do surgery. So these physician assistants are critical. They gain you access to good spine surgeons, good spinal physiatrists, and they really know what they're doing. They can really get the ball rolling in terms of treatments. Excellent. Well, everyone have a good night.
Thank you, doctor.
Thanks,
Everyone,
Melba.
have a good night, everyone. Thank you for attending.